Hello, this is Michael Altos, and we are continuing our discussion of the allergic response from Bearish Chapter 12, and this is video part 3. Now we're going to discuss in more detail the perioperative management of patients who have known allergies. Remember, the first thing we need to do is clarify if this is even a true allergy or some other adverse reaction or toxicity. We know that there are pharmacologic side effects to drugs. There may be predictable dose-related toxicity. This may vary depending on the route of administration as well as other coexisting conditions at the time of exposure. Remember that just because a patient had a prior uneventful exposure to a certain substance does not eliminate the possibility of a subsequent anaphylactic reaction. Any antigen can cause an allergic response, and different people will have different responses. In the OR, the most common causes of an allergic reaction are neuromuscular blocking agents, latex, antibiotics, and chlorhexidine. But there are many other substances that could be implicated, and they are listed here on the lower part of the slide. They include local anesthetics, induction agents, NSAIDs, protamine, colloid volume expanders, blood products, especially in patients who have IgA deficiency, bone cement, drug additives, insulin, mannitol, methyl methacrylate, radiocontrast dye, and vitamin K. And the list continues. Neuromuscular blocking agents are often thought to be one of the most common causes of intraoperative allergic reaction, classically cited at about 60% of the allergic reactions, although recent studies have challenged this number. The IgE antibodies that lead to this reaction may be antibodies to ammonium ions, which are found in many household detergents, toothpastes, and cosmetics. The agents most likely to precipitate a reaction are thought to be rocuronium, succinylcholine, and atracurium. And these drugs may also have some cross-reactivity with other neuromuscular blocking agents and potentially even morphine. And so patients who are thought to have an allergic reaction to neuromuscular blocking agents should really be skin tested prior to future anesthetics in order to clarify which substances they can safely be administered. Remember that certain neuromuscular blocking agents, like atracurium and mivacurium, can cause histamine release, and therefore they may be causing a non-immune histamine release, and this should be distinguished. Local anesthetics do not commonly cause a true allergy. Patients who have a true allergy will have symptoms like urticaria, bronchoconstriction, laryngeal edema, but often people describe an allergic reaction after experiencing some other adverse reaction. For example, systemic local anesthetic toxicity, which would be manifest by hypotension, tinnitus, and seizures, or reaction to an epinephrine additive, which would manifest as tachycardia, hypertension, and palpitations. Remember that allergy to ester local anesthetics is much more common than allergy to amides, and this is probably because ester local anesthetics are metabolized to para-aminobenzoic acid, which is an allergen. But there is no cross-sensitivity between esters and amides. A patient who is allergic to ester local anesthetics should be able to get amides safely. But we should bear in mind that various preservatives can cause an allergic reaction. For example, methylparaben, which is found in all sorts of local anesthetics, is metabolized to para-aminobenzoic acid. And other allergens exist as well, like sulfates, such as sodium bisulfate and metabosulfate. So we recommend that if you have any patient with a history of allergic reaction to local anesthetics, all future local anesthetics should be preservative-free in order to avoid this potential source of allergen. Protamine can cause allergy, especially in diabetics who have had NPH insulin exposure, patients who have a seafood allergy, and patients who are post-vasectomy. Protamine has other adverse reactions as well. For example, it causes direct histamine release, which can cause hypotension, not to be confused with an allergic reaction. And protamine also causes activation of complement and deposition of those immune complexes in the lungs, leading to pulmonary hypertension. Allergic reaction to propofol and barbiturates tends to be very rare. Allergic reaction to opioids is also quite rare, but remember that morphine can cause direct histamine release. We should speak for a few minutes about antibiotics, which are another common cause of perioperative allergic reaction. A true penicillin allergy is associated with 3 to 4 times increased risk of allergic reaction to any other drug. So we should take penicillin allergies seriously. And this is important because cross-reactivity with cephalosporins and carbapenems is controversial, especially since most penicillin allergies are not true allergies. This slide shows the molecular structure of penicillin and of cephalosporins. You can see that penicillin has the beta-lactam ring, indicated by the arrow, and it has on the acyl side chain an R group. And this R group varies with different kinds of penicillin derivatives. This is the side chain for benzyl penicillin, which is penicillin G, a similar side chain for ampicillin, and all of the other cillins have other side chains. Here is cephalosporin, again with the beta-lactam ring, and with a few different side chains, R1, 2, and 3. If we look at this R1 side chain, there are some cephalosporins whose side chain is remarkably similar to that for certain penicillins. However, if we look at cefazolin, which is the antibiotic we most commonly use in the operating room, you can see how its side chains are radically different from a molecular standpoint than anything we see in the penicillin, ampicillin, amoxicillin family. So if we look at drugs that are likely to have a cross-reaction with each other, either in the 7 position or in the 3 position, we see penicillin may have cross-reactivity with cefoxitin, amoxicillin and ampicillin may cross-react with cephalexin or Keflex. But Kefsol doesn't look like it's going to cross-react with pretty much anything. It's got completely dissimilar side chains. Again, looking at the beta-lactam ring, which tends not to be the source of allergic reaction, but instead looking at the side chains, at the R groups, which usually are the source of allergic reaction. The take-home message here is that not all cephalosporins are the same, and in fact, there are people who think that Kefsol or Ancef is just the IV form of Keflex, but we see that that's not true at all. And since the allergic reaction tends to be to the side chain and not to the beta-lactam group, it's probably safe to give cephalosporins, especially cefazolin with its unique side chain, and it's probably safe to give carbapenems if your patient has had a minor penicillin allergy, a rash or a fever or something like that. But because there is some risk of cross-reactivity, it's probably reasonable to avoid cephalosporins and carbapenems in patients who've had an anaphylactic reaction to penicillin. Now, often we'll be asked to give a test dose of the drug. And let's just be clear that a true immunologic test dose, which is done by an allergist, involves multiple serial dilutions until the allergen is at a very, very, very minuscule concentration. And then the drug is given usually as a skin test, and the patient is observed for some sort of an allergic reaction. However, a pharmacologic test dose, where we give 1 milliliter of a 10 milliliter syringe, is thousands and thousands of times more drug than is needed to precipitate the cascade of an immunologic-mediated allergic reaction. So we should not ever think that a test dose is somehow going to prevent a full-blown anaphylactic reaction. It may prevent a non-immune-mediated anaphylactic reaction, that is, an anaphylactoid reaction. And usually when I do a test dose, I'm doing it just to make the surgeon happy because they've asked us to do it. But if I have a serious concern about an allergic reaction, then I will not give any test dose. I'll leave that to the allergists. Finally, latex allergy should definitely be discussed. Even though it's not a drug, it's a common allergen found in the operating room. People who are at high risk for a latex allergy include healthcare workers with their common exposure, patients who have spina bifida and those with urogenital abnormalities. And there seems to be crossover with patients who have allergy to bananas, avocado, and kiwi. Atopic patients are also at increased risk for latex allergy. This is an occupational hazard. The incidence of latex allergy has been shown to be greater than 15% in anesthesiologists, especially during the time period when latex was very, very common. A significant percentage of drug allergies that occur during anesthesia may actually be due to latex. And unlike other allergic reactions, the onset after exposure can be up to 30 minutes. Remember that latex is found not only in rubber gloves, but in an assortment of medical devices. Latex caps for drug vials also can precipitate reaction in patients who are very sensitive. So just to summarize, we should clarify when a patient tells us that they've had an allergic reaction, if it was a drug allergy or a drug toxicity. The mechanism of these two reactions is very different, an antigen-antibody reaction versus something having to do with the chemical properties of the drug or perhaps the patient. The manifestations are different. The classic allergic symptoms of hypotension, bronchospasm, and urticaria versus the variable manifestations of some drug toxicity or side effect. Allergic reactions are poorly predictable, whereas drug toxicities are usually quite predictable. Drug allergy requires some sort of previous exposure, whereas toxicities and side effects do not. Drug allergies are not typically dose-related, whereas toxicities and side effects usually are. The onset of action for a drug allergy is almost always very short, especially after IV exposure. And drug allergies are far less common than drug toxicities and side effects, especially with sufficient dose. That's the end of this recording. We'll finish up the chapter in the next video.